Hello, my name is Harshini Ashar, and in this talk, I will be sharing some of our work on the feasibility of using focused ultrasound heating in combination with antibiotic-loaded thermosensitive liposomes for the treatment of implant-associated biofilm infections. Osteomyelitis is a bacterial infection of bone typically caused by Staphylococcus aureus bacteria. It requires long-duration treatment with a combination of antimicrobials, but infection recurrence is common. In extreme cases, some immunocompromised patients undergo extensive debridement and amputation procedures to correct the condition, significantly increasing morbidity and healthcare costs. Thus, there is an urgent need to develop new non-surgical treatment modalities for osteomyelitis treatment. Keeping this in mind, we hypothesize that using antibiotic-loaded low-temperature sensitive liposomes, LTSLs, combined with FUS-induced heating will enable heat-targeted and on-demand antibiotic delivery, as well as synergistic bacterial killing within infected bone tissue. So very briefly, LTSLs are spherical lipid bilayer structures with an aqueous core. We use the remote loading method to entrap ciprofloxacin within the LTSLs with an encapsulation efficiency of more than 70%. Their size range was 160 to 180 nanometers. When we measured the release of Cipro as a measure of temperature, the CIP LTSLs released 100% of drug load at 42 degrees Celsius. Next, to induce osteomyelitis, we surgically implanted an orthopedic K-wire into the medullary cavity of the femur of Wistar rats. A 100 microliter inoculum containing 10 to the power 7 CFU of MRSA was injected into the cavity. At 10 days post-infection, histopathological analysis was conducted and changes indicated signs of chronic infections. These included inflammation and fibrosis of the periosteum and cortex, as seen in figure A on the bottom. There was presence of necrotic bony tissue and pus, as seen in figure B, and also presence of clumps of bacteria dispersed throughout the bone, as seen in figure C. Thereafter, for the experiment, we infected rats bilaterally. 10 days later, we treated with FUS and antibiotic, and 24 hours later, tissues were harvested for CFU counts and tissue Cipro measurement. Our groups for comparison were CIP-LTSL, free Cipro, both with and without FUS, and the FUS control group. Each animal served as a non-heated internal control. So the figure to the left shows the treatment planning scheme. We used a preclinical HIFU system from Alpinion with ultrasound-guided treatment setup. The anesthetized animal was mounted onto the 3D axis as shown in the figure, and using ultrasound guidance, the femur was then aligned at a fixed focal depth to define the target boundary on the X, Y, and Z axes. We used 50% duty cycle, 5 Hz PRF, and a power of 12 watts. Which generated about 50 to 55 degrees Celsius at the focus, and the total treatment time was about 40 minutes. So this is the general flow of the treatment. Once the bone was aligned, the software was used to select an ROI at the muscle-bone interface as seen in the figure on the left. For automatic rastering along X-axis, upon initiation of FUS treatment, free Cipro or Cipro LTSLs were injected via tail vein at 10 mg Cipro per kg body weight. 7 to 8 points were treated at 300 seconds per point, covering the entire length of the femur. 24 hours post-treatment, we assessed the tissue Cipro concentration and observed a significant increase in antibiotic delivery with LTSLs in the heated region compared to the other control groups, thus demonstrating that liposomal antibiotic with FUS can be used to improve drug delivery to infected bones. This increased Cipro delivery correlated with the therapeutic effects of the combination therapy, where we saw significant reduction in CFU of biofilm bacteria on the implanted wire, as seen in the graph on the left. Although not significant, we observed a similar pattern of log CFU reduction in the infected bone using the combination therapy, as seen in the graph on the right. So in conclusion, our early findings suggest that FUS bone heating combined with antibiotic-loaded LTSLs can selectively improve bacterial killing. We believe that by further improving liposome focusing and optimizing the duration and frequency of FUS treatments, we can enhance non-invasive eradication of chronic bone infections. We are currently trying to understand the mechanism of FUS-driven antibiofilm effect, as well as its impact on immune microenvironment. With that said, I would like to thank my PhD advisor, Dr. Ranjan, all the lab members and collaborators for supporting this research effort. I'd like to thank the funding agencies and thank you all for your attention.